So the research team is obviously anybody who's doing it, and for those who are not doing it, I'll go to them one by one. The PI, of course, is the leader of the team, the conductor of the orchestra, the boss, the one who, that is true more or less depending whether you live in Austria or Germany or Italy or in Israel, where people react to you differently. Then there's the sub-investigators, which are staff members, residents, trainees. You may have students and others. The coordinators, which could be nurses, technicians, social workers. Whoever you need in your team, you have to recruit for your needs. Like we saw here, we have geneticists and molecular biologists. And then administrative and secretarial, which is becoming more and more widespread. And we are very fortunate that we have a half-time person, my personal assistant, who's actually trained by profession. She's a lawyer. And she does not practice law in Israel, but she's outstanding at reading the small print on the contract. So this is what she knows very well. So just a few thoughts on carrying on also from Heinz. Now, when you're a resident or a trainee or at the beginning of your career, now I know this morning we said a good way to start might be to join a group that's doing clinical trials. But basically, what are we telling the guys in the department? And I had this conflict in my mind over all the years. And I don't know the exact answer. I suppose it depends on the person. Some people go one way, some residents go another way. But the advantages, the pros, a person starts in the profession, he has early access to the latest treatment strategies. He gets straight to the top investigators and lecturers. He's exposed to research methods very quickly because you say, here, read the protocol. I don't know if anybody does that, but they're supposed to read the protocol. He knows what's an informed consent form, ICF. GCP, good clinical practice. What are the criteria? What are the inclusion-exclusion? What are the definitions of the events? What's an MI? It's easy to say patient post-MI. What's an MI? It's not easy sometimes to define. What's the statistic plan? And he has to pay attention to every detail when he's completing or helping usually our coordinators do the CRFs, the forms, but he has to learn. In the meantime, this guy who's now starting a career in cardiology this is an opportunity to interfere with his independent thought. Because the protocol's already been in a multi-center study, when he's doing a multi-center study, it's all been done by others. I mean, you know, a lot of people have thought about this. He's got no time for independent research and innovation because he's doing his regular job, his regular hours. He wants to do research, so he's doing a multi-center trial. He's looking for patients, and he's not thinking of his own ideas. And basically, when we try and be very nice to everybody, but when somebody's asked me for the 100th time, why didn't they design the study differently? You know, there's a time when you say, well, this is how we're doing it. Sorry, that it's not so great. And he gets fewer publications. Or there's a major issue in university promotions. And now our university have a whole category where they've put in of collaboration in clinical trials as a separate category of events because nobody knows how to deal with this, except the people who sit on the committee who understand. It means you've spent time in research. You're not the first author. You're not the last author. You didn't design it, but you've been exposed to research. So you should get some credit. The question is how much. Are you an author on the paper, or are you just a collaborator? And these are pros and cons that we have to learn. It's an adaptive process as we go. When doing the trial, I think we've actually heard a bit about this. You have to identify the patient, you have to motivate him, you have to be available for the procedures. And in the informed consent, please do it correctly. But this is a legal document. I mean, you can actually you should go to jail if you put a patient in a trial and he has not signed consent. I mean, this is criminal. And even though you think he may have understood it, but what's not written in research is not done. So if it's not documented, it didn't happen. Then follow the protocol. Reverse record the findings. There's a lot of work. You've got to make sure to dispense the treatment, plan the visits here, update this area, blah, blah, blah. Report to the GP. The GPs are very important, as Heinz said. And in fact, now we have a new generation, I think most countries, of very well-trained GPs. They do family practice as a specialty, and they know a lot. And if you take them with you, it's good. If you don't, we have a lot of problems with it. I have a lot of patients who said, after I talked to my doctor, I don't want to do this. And fair enough. Now, the role of the monitor, I've made some comments about monitors early on, but it is a method for ensuring integrity of the trial. Somebody's got to be sure the patients are genuine, that you haven't fabricated data. This has happened, and it will happen. Have we selected the patients properly? I don't think a monitor should be a policeman. or a traffic warden. I think she should be an assistant helping us to understand the protocol, because it's so difficult sometimes to understand the exact wording. You weren't there when it was written, and help us find the patients, do the procedures, report the events, and verify the storage and the use of investigational product. This was pointed out. We were involved in where a site moved to a new premises, and before they did that, we were told immediately by the monitors, if you're transporting the investigational product, make sure you're monitoring the temperature and put thermometers in it and make sure that it's not exposed to heating or the wrong temperatures. The monitor may assist in certain situations by interpretation and various other things, and the level may vary. Some studies are monitored remotely, some are on site, some are monthly, some are bi-monthly, some are complete, some are incomplete, depending on the budget, depending on the importance of a trial. I work with several groups who think that the monitoring has been overdone to a large extent, depending on certain trials, and others think the opposite. There are some potential issues when getting on with your monitor. The monitor represents the CRO or maybe the sponsor. She's got a conflicting motivation, or he's got a conflicting motivation. I pointed it out this morning. They really look at it from a defensive point of view. Their motivation is bureaucratic. They're not really medical. I've had a very irritating monitor who quite correctly says that, I don't know anything about EKGs. And so when you report the follow-up EKG in the system, I want you to report it very carefully. And which, I've been in this for, like all of us, for a lot of years. And then she came and said, the EKG's changed, you should report it as an adverse event. I said, where did it change? She said, before it had something called APBs, and now it does not have APBs. So the patient, does this mean it's an adverse event? And this is some of the stuff that those of us who do trials probably sympathize with me, and at which stage I nearly withdrew from the trials. I did not have the time or the patience to explain it. But then I decided that I would basically not lie, but be a little bit more careful in my ECG reporting and not actually include APBs when they were there in the beginning. Then I wouldn't have to justify why they disappeared later on. Maybe it's an effect of the drug and maybe it isn't. So these are the things that I'm sharing with you, that we all have these problems, but it's a two-edged sword. Some things are good, some are bad. Nonetheless, you have to have a good working relationship. And the studies that we do best in my experience, that we recruit the most patients in, when my research nurses and team get on well with the monitors, they love to do the study and they make extra efforts to do it. And when we, in one of our PCSK9 studies that we're involved in, we have more than 50 patients randomized, because my research nurses, they love the monitor. They talk about everything that people talk about or women talk about. But they all happen to be women. It's not against women. They just happen to be women. And they do very well. Okay, now the sponsors and investors. These guys are there for profits and survival. And really, I would not like to be in the shoes. I think, I wonder if Juan Carlos agrees with me. I would not like to be in the shoes of the guy, the cardiology is responsible for the medical conduct of a trial in a big company like GSK or Novartis, because his job's on the line. He makes the prediction. He's decided, let's go for it. $100 million, $200 million. And when that's getting the end and he's not going to see a result, this guy is not going to be popular. The company image is benefits from research, and you never get it funding for non-profitable trials. As we discussed this morning, you can't find anybody to find a study is vitamin D good or bad, or even aspirin. We know the difficulties here. The sponsor needs to provide balance to the trial, usually through the medical manager of the project, and he interrelates with the committees. And again, we all know good people there, those of us who do trials, and it can help you along. Now, when you're running the trial, you should always keep a finger on the pulse. It's like a patient. You want to check the recruitment characteristics, as we've heard, but in keeping with Giuseppe's idea of an adaptive design, we've been doing adaptive design, Giuseppe, for many years at a small extent. In other words, you set up, we're going to examine a trial of patients, say, post-MI. We want to include X amount of diabetics, for instance, and X amount of non-diabetics. So you might have to cap certain groups as you go. And I think this is legitimate. If you see that all the recruitment in the centers that you've selected are non-diabetics, for whatever reason, you have to figure out why is this happening, but watch it, because you may end up with the wrong population. It's quite legitimate to say we're not changing the protocol. You're allowed to change some inclusion criteria if you can justify it. We want more exposure. And this taking into account the external validation, because you want to make it applicable to a real-world population. You have to track adherence or compliance to treatment, because if it turns out at the end of the trial that nobody took the drug and nobody took the placebo, then obviously nobody's going to do better than anybody else except by the play of chance or other medical treatment. You have to track the event rate. When you calculated the power, you assumed that a certain number of people are going to get a certain number of diseases during the period of the trial. And if you're not on track, and this is a sine qua non of clinical trials, I don't think I've yet, until today, seen a trial where the event rate of the trial has been higher than predicted. It's always lower. Because once the patient gets into a clinical trial, they get better treatment. And they themselves take better treatment. One of the problems we have, we're all talking about lipid lowering, because the PCSK9 studies are here and Improve It just ended, is that the patients now take more care of themselves. They do better diet, as Heinz said, and the event rate goes down because they're better treated. So if your event rate is low, you're never going to get results. You can do three things. You can increase the number of patients, you can increase the duration of follow-up, or you can alter your inclusion-exclusion criteria if you're managing the trial to adapt. But you can't change too many other things. And then please check the retention, meaning patient compliance in taking the study treatment and patient retention, coming to visits, coming to follow-up, and not getting lost. And I want to discuss this very important point in a minute. And of course, the consent status. Sometimes he has to be reconsented. This is another stupid development of bureaucracy. Totally waste of time. I agree with this. But every now and then I have to explain to the patient, you have to sign another new consent, because the trial now has, worldwide, is going to have another 2,000 patients. And I'm told by good clinical practice, which to me is really irrelevant in this situation, that you need to know that there are 20,000 people in the world in the same trial and not 18,000. And the patient doesn't really care how many. All he cares about is that he's in the trial. But anyway, that's how we have to deal with it. And you have to explain to the patient that nothing's happened, and it's a lot of work. For follow-up, plan well in the beginning. Use contact persons, treats and tricks. So there's always ways to do this. We don't have time to get into it. Watch out for missed or late visits. It'll make the data reliable or not. Drug supply may be a problem. Motivate your investigators and your patient. Telephone calls, groups, we've heard about that. Now, there's another thing called adjudication. I don't know if anybody else is going to touch on this. But the aim of adjudication is to standardize the interpretation of clinical events. Somebody gave a good example. I'll give you a more simple one. What is an MI? The patient comes in with acute coronary syndrome. He has a cath, he gets a stent, and then his troponin does something. And it's very difficult something to know when the troponin change. Is this part of the original event? Or is this as a result of the procedure, or is this change because of your intervention, your drug trial? Isn't that right? So sometimes so an adjudication committee can standardize it according to the rules. That's all they do. They don't know it better than the site. They don't know it better than you. Don't take offense if at the beginning I used to do that. Well, I need somebody in the US to tell me if this is an MI or not. I know better than they do, maybe. But the thing is, they standardize it. That's the difference. It should not change the outcome, but it can, if depending on how it's done. Should it be central or national? There's some studies we work with where all the events in our country are adjudicated by independent local adjudicators, and they read all the data in the native language. I think this is a great system. I really wish everybody would do studies like this. I would highly recommend it. In fact, put it in the regulatory authorities, Giuseppe, that adjudication should be done in the native language. Because for other studies, want us to send in to collect the thing, it's translated by non-medical translators. And when I read, because English is my first language, so I read what they've written about the event that happened in my own patient, in my own department, which was from Hebrew to English in the situation. I sometimes say that's not exactly what happened. The translation didn't get it right. But that's another way of doing it. And again, adjudication, be total or partial. A new way to streamline trials is a system we're using in the COMPASS trial, where it's a computer algorithm, looks at the database and looks at the event as reported by the investigator. And in about 70 or 80% of cases, it turns out, that yes, you can validate it. There was an MI, so there's a troponin rise, there's ECG changes, let's make it simple, everything fits. In about 2/3 of the cases, that works. And in this particular trial, which is 20,000 worldwide long-term experience, only the events that do not satisfy the algorithm are going to be adjudicated. It's only 20 or 30%. And that's far less work and saves an enormous saving in costs and time and money. And if that works, it'll maybe be a precedent for future trials. Now, this is what I really wanted to spend a bit of time on. And what everybody talks these days about patient retention, I think this is a very confusing word. Every patient's retained. No patient ever leaves a clinical trial. When the patient signed consent, he signed consent. At that point, it's dubious whether he's in the trial or not. Now, the companies say he's in the trial because he signed consent. I think he's in this trial when he gets the first dose of medication. Because we've had a case where the patient signed consent, and then while the doctor went to the phone to randomize the patient, the acute coronary syndrome, the nurse said, come back, the patient's crashing around us. So the patient sort of collapsed, had to have some resuscitation, and got urgently taken to the cath lab. I think the patient made it. But the trial was abandoned in all this thing. So the patient never got a randomization number, but he did sign consent. Is he in the trial? Well, he wasn't randomized in the trial. You can argue about this for days. But once he's taken, let's leave that. Once he's taken the first dose of the drug, he's forever in the trial. Because if you get one dose of a drug, you never know, in a year's time, even if you stop it after one dose, maybe that dose changed something in your coronary artery that day that meant you did better or you did worse. And so whatever happened to him should be recorded if at all possible. It's not right to say, well, he's not taking the product, so we don't have to worry about him. You follow every patient at the end of every trial, whether he takes on drug or off drug. The more he takes the drug, the more compliant he is, the more chance you have of getting a positive result with your hypothesis. Because to get a positive result, you want all the patients on the test drug to take it. But if nobody takes it, nobody's going to do better or worse. If you can't find anything else, at least find the vital status if it's in the public domain. And there are ways of finding this through national records. You have to consult the lawyers, what's allowed, what's not allowed. Nowadays, I would put in informed consent that when he signs the consent, that even if I withdraw consent and I don't want anything else to do with you, he agrees at the beginning that you will be allowed to use my medical records, which in our country are mostly computerized and available through a national record system to qualified persons, or the Ministry of Health, or the Ministry of the Interior, whether he's dead or alive, or I guess the Internal Revenue, the tax department, or the people who bury you. You can find these things out. And the patient should consent in the beginning if you want to make sure you keep your patients, that he agrees to be followed. Even if he withdraws his consent to trial, he doesn't find that I don't see where it harms him. In anonymous fashion, the correct data will be recorded. Is that acceptable if he signs the consent at the beginning? I think so. Not in this country? Why not?
You could ask for permission. You can ask for permission when you take consent, and when they withdraw from the study, you can ask for permission to carry on.
Oh yes, well, if you ask for permission when they say, I don't want the drug, I always say, oh, that's fine, but we'll follow you anyway. Is that okay? And they say, yes, you can write that down.
But they need to be randomized, no?
Pardon?
They need to be randomized.
No, after they're randomized, they stop the treatment, and then they say, I don't want any more visits, I've had enough of you, I don't want to see you again, whatever it is. But then they usually say, but you can call me up from time to time, and they allow it. The point was that there might be a way of putting into the consent that he agrees with his vital status, if he's dead or alive, is used, that data is used independent of him. But the lawyers could argue on that. I agree with you. I've had two interpretations on that one. So one lawyer said that if he withdraws consent, then that decision is no longer valid. Another lawyer said, yeah, well, did he write to you a letter and put in writing that I withdraw consent, because the first was signed, so the second one should be signed. And you know, lawyers can argue about anything as long as you pay them.
Yeah, I mean, in this country, your information sheet records.
Well, we can talk about this afterwards. I think it's a very interesting subject. Also, the lawyers have all said, if it's in the public domain, that's fine. I said, what's the public domain? And then you can define that. I mean, sometimes, you know, it's a well-known person was, let's say, a well-known person was assassinated or shot or died or crashed in a plane, like we're thinking about these days. I mean, it's in the newspaper. I mean, so I don't see, if the whole world can read it in the newspaper, why shouldn't it be in the trial data that this patient is dead? If he didn't want you to report it, and so on and so forth. So anyway, this is a separate discussion which we can continue over tea. Now, what I would like to do, and spend a little bit of time on this, is talk about the importance of this when you analyze the data. The issue is this: if the patient is lost, withdraws consent and then is lost and you have no data. So the regulators can argue it this way. You gave him a new treatment. The new treatment, you don't know what's happening, or he's lost, he disappeared and nobody knows how to find him, or withdrew consent and then it's the same, you don't know how to find him. Let's assume that this drug, the worst scenario, if you have to protect public safety. So let's assume if he's not here, he could be dead. You've killed him with your drug. So we have to assume that if he took the real active treatment, he could be dead. If he took placebo, Well, that's not supposed to have killed him, so then he's alive. So let's just do a little exercise here, numbers. So let's assume you have a trial of 2,000 patients, 1,000 got placebo, 1,000 had active drug. The placebo had 200 had an event or were dead, reached the endpoint that you were collecting was met in 200 of 1,000. And on the active drug, only 150, which means that it looks like 150 on the drug versus 200 on placebo. This looks like a good drug. You saved 50 events for every 1,000 patients. It gives you a relative risk reduction of 25%, and let's assume a p-value, which I don't know if I invented that or at the time somebody calculated, was 0.0, but it's certainly a significant reduction, and this is a significant result. Now let's assume you lose to follow-up or withdrawn consent and you have no way of getting the data, it's the same. 5%. That means 50 patients, that's all, in each arm, 5%. So in the placebo arm, well, if he's gone and you don't know where he is, he wasn't getting a drug, so the drug didn't kill him. I mean, if he's gone and done, you've still got 200 event or dead. But let's look at your 150 here. And you say, well, maybe you've lost 50 patients. There they are, the 5% is 50. You've got 150, but maybe the 50 you've lost are all dead. And that's why they didn't come to your clinic, because they can't, they're buried. So you have to add that in. In the worst case scenario, which the agency might take into account, they could say the active drug has an event or dead in 150 plus 50 of 200, total ineffective drug. And this will be a reason why a drug may not get approved at the end of the trial, and why most studies will aim at an event or loss to follow-up of less than 1% or even less than 0.1%. And some of the I've heard of some multiple groups, US-based, will hire private detection agencies to find the patient. And then it becomes a whole issue if you're allowed to report it, because if you call up the patient, is a great example, Lucy, and you say, oh, this is Dr. Lewis on the line. I just wanted to know if you're dead. And you say, yeah, I'm around here, but wait a minute, I didn't want to talk to you. I'm never going to talk to you again. Slams the phone down. Now, I know he's alive. He shouted at me. So do I know he's alive? This is the issue. Now, are you allowed to report that he's withdrawn consent, you see? So these things become very interesting for discussion. And this slide should be very important to be kept in mind. Don't get into the situation. Don't lose the patients. So I think that's enough for this part until we can have further discussion. Again, remember to join the group. I'm told that Corinne Gomez from the ESC is going to mail everybody in the room who is attending this and who registered with this web address, and to make it easy, if you'd like to join up and sign up to get information and further stuff, you'll get a link just when you get some time in your hotel room or wherever you are at the waiting for your transport. Go to the link and complete the thing, and then if Stefan Agarwal likes you, that he'll accept you. Stefan's a very likable person. Thanks very much.